So this is going to be pretty easy for all of you now. Where's swallowing processed pre-stroke? Here in the DLPFC. Some overriding and supervisory role of the bolus of food that's coming into your mouth or that swallow of liquid requires the DLPFC to make a decision of, does this feel okay? Should it be going ahead and being processed down? What's the temperature feel like? Is there some odd bone-like structure that I seem to be chewing on? Rather than make it automatic and just shove it back down, let's make a decision here in the DLPFC to change it up. So ultimately, the swallow itself is going to be processed down here in the basal ganglia on a procedural memory basis. If everything feels okay, tastes okay, and from a temperature standpoint is processed okay, just go ahead and take it, shove it back down, taste it. Very procedural in nature, can continue to listen intently to a conversation and not be distracted away. These procedural memories require some degree of attentional supervision to make sure everything's right, so these two structures are essential. But where does swallowing reemerge after traditional stroke rehab? If therapists cue the patients to think about the movements and the internal representation of what's occurring, and the patient's focus on the body parts of chin tuck and lip closure and pharyngeal movements, then the patients are engaged to actually process the swallow up here. And remember, that's not what we just talked about, that swallowing was processed here in the motor strip. So, movement-based representation and the cues that follow in our typical rehabilitative approaches force that task of swallowing to be very conscious, to be very broken down, to be very sub-task or part task, and to be processed in the M1 motor strip. So then this will be a pretty easy one for you as well. Where should swallowing reemerge after traditional stroke rehabilitation? Well, perhaps the question could be, where should swallowing reemerge after more contemporary stroke rehabilitation? Well, obviously, we'd want to put it back where it belongs in the DLPFC, and then also in the basal ganglia procedural memory center. And it is actually the introduction of a dual task with goal-based integration that forces this automaticity, shoving the task back down into the basal ganglia due to the imposed attention constraints. But because we're at the point in the course where we are, that's not a surprise to you. You understand that.